Hello, everybody, and welcome back to Emergency Medicine Quest. In today's lecture, we will discuss about acetaminophen toxicity. Before we continue, make sure to like, share, and subscribe to the channel for more such content. Let's first start by discussing about acetaminophen's pharmacology. So, it's a very commonly prescribed painkiller, and the peak plasma levels for this drug happens at 1 hour with complete absorption taking place at 4 hours. When acetaminophen is taken in a therapeutic dosing, 95% of it gets converted into non-toxic metabolites and gets excreted via the urine. But 5% gets converted into this compound called NAQPI, which is a toxic metabolite. In a normal person, this NAQPI binds to our glutathione and gets converted into a non-toxic compound. But if the dosing of acetaminophen is toxic or in a patient with certain amount of comorbidities, this process can get overwhelmed and so NAQPI will start binding to the liver cells causing liver cell death. If we discuss about the clinical features of acute early acetaminophen toxicity, so obviously if they present to hospital immediately after taking the acetaminophen, they are going to be asymptomatic. But if they present after a while, they can have non-specific complaints. And in an acute acetaminophen toxicity, it can lead to liver failure. So here's a very good chart to basically understand the time frame and understand what we can expect from the patient. So from 0 to 12 hours, they can have nausea, vomiting, malaise, anorexia. From 8 to 36 hours, they will start developing right upper quadrant tenderness on top of their existing complaints. We only see liver failure if it occurs 2 to 4 days after the ingestion. So it will manifest either as hepatic encephalopathy, metabolic acidosis, coagulopathies, and after 4 days, there will be recovery from all this. The next step in management of these patients is to do a risk assessment. So the risk that we are assessing is how likely is this patient going to develop liver injury. Generally, in an acute toxicity, less than 10 grams or less than 150 mg per kg does not cause significant liver toxicity. But regardless of whatever the patient reports is the number of tablets they took, serum acetaminophen level has to be checked. Now, the time of ingestion is very important. If the patient is presenting less than 4 hours after ingesting acetaminophen, then we have to get our acetaminophen levels, serum acetaminophen levels at 4 hours. We don't start a management, we will only provide symptomatic care and we will get our serum acetaminophen levels. Once we get the serum acetaminophen levels, we are going to plot it on the treatment normogram, which we will discuss about. If the serum acetaminophen levels are below the treatment line, then this patient does not need any management. So the idea is that do not get serum acetaminophen levels less than 4 hours, because remember we discussed in the pharmacology that acetaminophen gets completely metabolized in the body only by 4 hours. If the patient is unable to give a time frame or the history is not reliable, then we can start the management for toxicity ASAP. Between 4 to 8 hours, if the patient presents again, we will get our serum acetaminophen levels, bearing in mind that it should not cross more than 8 hours to get the levels. So if we are anticipating that these levels will take more than 8 hours, we start them on the treatment for the toxicity. And if the patient presents with more than 8 hours of ingestion, then we directly start them on our treatment. Along with this, if any patient presents with signs and symptoms of hepatotoxicity, we also start the treatment ASAP. Moving on to chronic ingestion. So the risk assessment in chronic ingesters is a bit more complex, And the need for treatment basically depends on two things, on AST and on the serum acetaminophen level. If AST is 2 times more than the normal level, or the serum acetaminophen level is more than 30 mics per ml, then this requires the person to receive the antidotal therapy. Those who do not meet this criteria, basically you can repeat the AST after 4 hours, and if there is no sharp increase in the AST as one would expect in case of acetaminophen liver injury, then there is no need for any antidote, as it is very unlikely for the patient to then have liver injury. This is a paracetamol treatment normogram, also known as a Rumac Matthew normogram. So you can see how at 4 hours there's a certain value which is part of the line. If the patient's value of acetaminophen falls below this red treatment line, they will not need any MAC, and this is only applicable for acute ingestion. If their value falls above the red line, then basically they need to be managed with antidote. It is important to bear in mind the two types of values we have. So we have either values in micromole per liter or in milligrams per liter. So whatever your institution uses, match it to that and then see how the patient compares. Moving on to the management of acetaminophen toxicity. So there are three key principles that we should know about. So there's decontamination, there's giving antidote, and then there is enhanced elimination. We'll talk about each in detail. Starting with decontamination, generally it is done with the help of activated charcoal. Now, the criteria for a person to be eligible for activated charcoal is if they have come within 1 to 2 hours of ingestion. Any patient that is asymptomatic and comes within this window is eligible for it, but the contraindication to receiving activated charcoal is if the person is low GCS or has altered mental status and is actively vomiting. Moving on to the antidote of acetaminophen toxicity, so it is NAC or N-acetylcysteine. If we just go back to our pathophysiology here right quick, we remember that NAQPI in an acetaminophen toxicity is not able to be converted into non-toxic compounds by glutathione because it gets overwhelmed. NAC acts just on that. What it tends to do is it tends to primarily increase the levels of glutathione so NAQPI can be converted into non-toxic compounds. There are two ways to give NAC. We can either give it orally or IV. Both are equally efficacious, but for certain reasons, IV is preferred. The reason is oral has got a very bad smell and taste, almost a rotten egg smell that is very difficult for the patients to be palatable. So they end up vomiting. And anytime they end up vomiting, that dose has to be repeated. So IV is preferred, but the caveat to IV is presence of anaphylactoid reactions, not anaphylaxis, anaphylactoid reactions. Mild anaphylactoid reaction, they will have some sneezing, skin changes, skin rashes. In moderate, it will accompany hypotension, and in severe, they will have angioedema, bronchospasm combined with the hypotension and other symptoms. If they develop mild anaphylactoid reaction, we just give them IV diphenhydramine 25 milligrams and we don't stop or pause the IV NAC infusion. If it is a moderate one, then we are going to slow or pause the infusion, give them diphenhydramine 25 milligrams, give them some fluids, and then resume once they feel better and the hypotension resolves. In cases of severe, we give them methylpred 80 milligrams IV. Generally, Epinephrine is not indicated unless the patient goes into a full-blown anaphylaxis. As for the duration of therapy, so if we are considering IV, then it's going to be a 21-hour protocol, and if we're considering oral, then it's a 72-hour protocol. For IV, we basically have to remember 1, 4, and 16. So the first bag of NAC, which is given at the dose of 150 mg per kg in 200 ml of D5W over 1 hour. The second bag is given at the dose of 50 mg per kg in 500 ml of D5W over 4 hours. The next bag is given at the rate of 100 mg per kg of NAC in 1 liter of D5W over 16 hours. So this is the regimen that is quite standard and followed. Oral, on the other hand, there's not much difference in the dosing. It's 140 mg per kg. The goal of our treatment is we need to make sure that the patient is asymptomatic. The serum acetaminophen levels are essentially undetectable, and there are no signs of liver injury. So the patient should not have encephalopathy, the INR should be less than 2, and the AST should be following a decreasing trend. As for enhanced elimination, which is done with hemodialysis, there are two criterias of when a patient needs hemodialysis. The first one is if the NAC is given. The second one is if the NAC is not given. If the NAC is given, the patient has altered mental status, metabolic acidosis, severe metabolic acidosis, increased lactate, and our serum acetaminophen levels should be 900. So if you've given NAC and the acetaminophen levels are more than 900 plus the other things, this patient needs dialysis. If the patient has acidosis, is altered, has increased lactate, and the serum acetaminophen level is more than 700 and the NAC is not given, then this patient needs also hemodialysis. This brings us to the end of today's lecture on acetaminophen toxicity.